and welcome to the Surgical Oncology Clinics podcast. I'm John Vassallo, the managing editor for Surgical Oncology Clinics here at Elsevier. Surgical Oncology Clinics is a quarterly publication consisting of review articles centered on a central topic important to surgical oncologists. For our second podcast, we will be discussing the July 2021 issue, and the topic is one that affects all surgical oncologists: palliative care. Leading the discussion will be our consulting editor, Dr. Tim Pollock, professor and chair of the Department of Surgery at The Ohio State University Wexner Medical Center in Columbus, Ohio. Joining him will be the guest editor of the palliative care issue, Dr. Bridget Fahey, the Victor and Ruby Hansen Surface Endowed Professor of Complex Surgical Oncology and Chief of the Division of Surgical Oncology at the University of New Mexico in Albuquerque. Welcome to both of you, and over to you, Dr. Pollock.
Thank you, John. I'm extremely excited to have with me tonight Dr. Fahey, who, as we heard, is a professor at the University of New Mexico, where she also serves as the UNM Medical Director of Surgical Palliative Care, being board certified in hospice and palliative medicine. Dr. Fahey is a national and international expert on palliative care, both in the surgical and medical realms. And therefore, we could have no better guest editor for this important issue of surgical oncology clinics of North America. As we all know, as surgical oncologists, palliative care is an extremely important element of the care that we deliver to patients throughout their entire care journey that impacts their quality of life, as well as the experience of their loved ones and their family members. This topic spans many different subjects, and this volume of surgical oncology clinics does a wonderful job covering in detail many different topics in the area of palliative medicine, including such disease topics as malignant bowel obstruction, peritoneal carcinomatosis, as well as strategies for optimizing perioperative pain management for the patient with cancer. Tonight, I will be touching on several of these great articles that are included in this volume with Dr. Fahey. So, Bridget, I'd like to welcome you tonight to the podcast.
Thank you so much, Dr. Pollock. One, for the privilege of getting to really talk and write about something I feel really passionately about, and also a chance to really showcase the number of surgical leaders that we have in the field of surgical palliative care, particularly as it pertains to patients with cancer. Absolutely.
So, Dr. Fahey, I thought we'd start off by discussing your article in the volume that discusses the current guidelines for the integration of palliative care in oncology. We know that palliative cancer and oncology are inextricably linked, yet we also know that there has been somewhat of a slow adoption and embracing of palliative care, perhaps especially in surgical circles until perhaps over the last decade. So I was wondering if you could kind of comment, if you will, on some of the guidelines of how we can better integrate palliative care into oncology.
Yeah, thank you so much. I really hoped with this first article to make the case for kind of where we've been and where we are right now, and why a surgeon should even care about this. What we know is that nationally, a third of all patients who need palliative care have cancer. I'll speak to our own institution. 50% of patients that are seen by the palliative care service have cancer, or at some state of their cancer journey. So I just, as you said, they're inextricably linked. I think that the thing that has really held us back over literally the decades that have preceded us to where we are today in 2021 is trying to disengage palliative care from end-of-life care only. It's certainly true that we have a significant amount of overlap in terms of the philosophy and the domains of care between palliative care and hospice care. But I think what's important for a surgeon is you don't do palliative care when you're done operating. You don't do palliative care when you don't have an operation to offer. You provide palliative care concurrent with our curative intent therapies. And when people ask me, why would a surgeon ever do palliative care? And my answer is because nothing says aggressive palliative care like bringing the surgeon in. It means I've got the full toolkit. I've got procedures, I've got medications, and I have a whole team that come with me. So I think that has really been kind of the first mission. And ASCO and other national organizations, Society of Surgical Oncology, Institute of Medicine, and so forth, have gradually been sort of getting the message and then getting the message out. I think that you can't talk about palliative care in oncology without talking about the Jennifer Temmel trial published in 2010 that showed that palliative care improved quality of life for patients and these are stage 4 metastatic lung cancer patients. And I think quelling the thought that palliative care was just about, again, end of life care, there was actually a small survival advantage in this rare group of patients that generally have a dismal prognosis. So I think, the goal of talking about integrating palliative care is to show that there is a need up front, really at the time of diagnosis, that those needs continue throughout the scope of a patient's cancer treatment, including end of life, but not exclusively at end of life.
Yeah, one thing that I was particularly struck in your article were the tables and the amount of empiric data that you provided. I agree with you. It seems to me one of the barriers to palliative care is this kind of conflation of palliative care with end-of-life care. And then perhaps the other challenge is that some people erroneously believe that there's a lack of robust data around the impact that palliative care can have around some kind of hard metrics such as mental health, quality of life, even length of stay, cost of care. So I was wondering if you could comment on some of the empiric data that you so nicely laid out in those tables in your article.
Yeah, thank you so much. That really was sort of one of the goals, was to say this is not just the one article that I cited by Jennifer Temmel. There is a growing body of literature that's actually been going on for many, many years, but I think most of us weren't focusing on it because we were looking at survival curves for cancer X or disease Y. So I think that, some of the best studied aspects of palliative care are around pain and symptom management. I think that there are some challenges about who you study and when you study them and how you measure it. But I think that the overwhelming theme is that patients who receive palliative care have improvement in their symptoms, particularly pain, gastrointestinal symptoms, which is really a domain of the surgeon many times, but also things like insomnia and fatigue. And I guess back to the question of why should a surgeon care? That's going to help a patient get through whatever treatment we have planned for them. It's going to help with their ultimate cancer outcomes. And then for those that are concerned about the financial ramifications, it has been shown to decrease some resource utilization. And this is not, again, pulling the plug on these folks. It's making sure that they're receiving goal concordant care. That if your goal is to die at home, or if your goal is to avoid a lengthy ICU stay in the unfortunate circumstance of postoperative complications, that we don't get those patients on a train and not be able to get them off.
Yeah, and one thing you touched on was the data around effective pain management when it comes to palliative care. And I wanted to transition to another great article by Hill and Lefkowitz that discussed a strategy for optimizing perioperative pain for the cancer patient, and really had this really interesting concept of total pain, and this idea of the importance of both biopsychosocial kind of pain and issues, along with somatic pain, and then in both acute and chronic. So I was wondering if you could touch a little bit about the role of pain management broadly construed within palliative care, and maybe touch on some specific points that surgeons should be aware of when they're discussing pain management with their patient.
So, we know that pain is common, that 53% of patients across the cancer continuum are going to have some degree of pain. And in over a third, this pain is going to be rated as moderate to severe. So this is not a trivial symptom for these patients and their families. And again, it can impact their ability to successfully engage in all aspects of their cancer treatment. And so I think what the authors did that's really important is they talked about assessing this up front. I think that for many surgeons, we start our pain assessments postoperatively and are not as aware as we should be of what a patient's baseline pain is, and also thinking and starting to set some expectations about pain management after surgery. And, I think in the era of the opioid epidemic that we're all living under, and being more savvy about the fact that there are other strategies for pain management other than opiates, it means understanding what those other domains of pain are. And I think it takes time. And I think this is something that none of us have in abundance, unfortunately. But I think the dividends of understanding the psychosocial stressors, the spiritual pain that comes with a cancer diagnosis and its treatment, how the cancer diagnosis is affecting the patient in the context of their family, can really help to make sure that our pain management strategies are being focused at the actual source of the pain, i.e. an opiate is not the cure for all pain. It may be pastoral care, it may be supportive counseling, it may be rehabilitation, it may be education to the patient and their family.
I was wondering if you could expand on that a little bit. Much of the article did spend some time on various approaches to pain management that did not involve opioid use. In particular, the use of gabapentin, antidepressants, esmolol, caffeine, and even medical cannabis. And I know you have extensive experience in this area, and I was wondering if you could just shed some light on perhaps what may be the different clinical situations or indications where any one of these non-opioid approaches may be appropriate for a certain type of pain or a certain type of patient or a given clinical situation.
Sure. I think it starts with understanding about the different mechanisms of somatic pain. For example, the pain associated with a malignant bowel obstruction is different than the somatic pain that happens with an incision on your abdomen, for those of us that still do open surgery here and again. And so thinking about what is the appropriate pain management for that specific type of pain. So I think that the gabapentinoids in particular, now I think many surgeons are well versed in the use of these medications for neuropathic type pain. And I think when you think about the number of our patients that have received platinum-based chemotherapy and the peripheral neuropathy that they're already coming in with, making sure that that is being optimized so that pain in your feet is not the thing that stops you from being able to ambulate postoperatively. For patients that are already on very high doses of opiates for whatever reason, thinking about adjuncts like ketamine, but that means working with your anesthesia team to be able to manage that somatic pain postoperatively.
And what about non-pharmacologic approaches? That was touched on in the article, including cognitive behavioral therapy, acupuncture, or exercise. These may be things that are even more out of our comfort zone as medical providers. And how can we integrate these non-pharmacological therapies or strategies into alleviating the suffering of our patients?
I think that it starts again with just talking to the patient. I think many of us would be surprised how many of our patients are already engaged in some of these non-pharmacologic therapies, but they are afraid to talk to their provider about it because they're going to think that we're engaged in some kind of fringe therapy. So I think asking them, and sometimes those are homeopathic supplements, but some of it is non-pharmacologic, as you mentioned. And this is also where the palliative care multidisciplinary team comes in. I will oftentimes have my social worker come in and do some of that cognitive behavioral therapy with them, some breathing exercises with them that are very simple to help them kind of reset anxiety that comes into whether it's going into chemotherapy or getting ready for a major oncologic resection. And then we do know that there is significant and growing data that about the use of acupuncture in particular for postoperative pain. And so but it means being familiar with what those resources are. My own institution, we don't have that as an in-house resource, but we do through our integrative medicine clinic. And so sometimes it just starts by asking the question, is that something the patient would be interested in?
I think that's a great point. Just signaling that as a provider, you are open to some of these alternative therapies that may benefit our patients. And while we may ourselves not be familiar with them, at least being open to them and perhaps facilitating for the patient, getting them connected with the resources that may be able to provide that for them. Another thing that you touched on earlier was the importance of goal concordance. And that is something that is near and dear to my heart. And I feel all too often, unfortunately, that there is incongruence between the goals of the provider and the goals of the patient sometimes. And there's just two ships passing in the night, and we're not getting that aligned. And I personally think that can lead to poor quality of life for the patient, decisional regret, anxiety, and depression. And as you know better than I, there is empiric evidence that, in fact, demonstrate that. And so I was really interested in the next article by Parker and Miner about palliative procedures for oncology, because I think there's a big continuum of what one might consider as a palliative operation. And not trying to be too facetious, but perhaps one could even consider that a Whipple, in some sense, is a palliative procedure, or other aggressive surgeries for cancers that have high case fatality rates. But I thought I'd ask you to maybe just comment on palliative procedures, how you construe this, and also what does that mean to you? You know, what are we trying to palliate? I think in some instances, if there's like a malignant bowel obstruction, it's maybe more clear than in other situations where, we may be trying to alleviate a patient's symptoms, but they may be near the end of their life, and we're trying to make this difficult decision about whether an operation is warranted or not.
Yeah, it's a great question. And I think the first thing that starts any discussion about a palliative procedure is, do you even know what you're palliating? And I think it was the classic statement, right, is you cannot palliate the asymptomatic patient. And so I think for both patient and provider and their families, everybody has to make sure that we're clear about what the intent of the procedure is. There was a relatively older study now out of City of Hope that asked surgical oncologists, whether or not a procedure was palliative, and they couldn't even agree on the definition. And was it because the margins were positive? Was it that there truly was a symptom they were going after, or was the operation done with non-curative intent? And I think we sometimes conflate those two terms, non-curative and palliative, and I think they're different. The oncologist understands this, I think, maybe a bit better than we do as surgeons. But I think that the article that Tom and his colleague wrote are really helpful, because I think it really does start with figuring out what is it that is our intent of the procedure, and then can I as a surgeon meet that goal? And then placing that informed consent discussion in this context of their overall cancer trajectory. So just as you said, these can be very difficult decisions to be made, particularly when somebody's time is short. But I think he does a really nice job of pointing out the difference between in relieving the symptom and improving the quality of life. And those two things aren't necessarily the same. But yet a patient may still deem a palliative procedure as, quote, worth it. And so I think we have to really understand what it is that the patient is hoping for at the end. And we as surgeons then providing a very candid assessment about whether or not we think we can meet that goal and at what cost, just as you said, with a 40% morbidity rate of kind of all-comer palliative procedures and a mortality rate of 11%. I think most of us don't go into the OR every day thinking that there's a 1 in 10 chance the patient doesn't make it.
Just to follow up on that, another concept that Dr. Parker and Dr. Miner highlighted in the article was this notion of the palliative triangle when it comes to communication around palliative procedures, and discussed in particular, the shared decision making between this triad of the patient's family, and the attending surgeon. And I know that you've had many of these types of conversations, Dr. Fahey, and I was wondering if you could share with our listeners maybe some tips about how to successfully kind of go about and help facilitate this type of conversation in the palliative triangle, if you will, and then maybe some common pitfalls that you have seen, surgeons or other healthcare providers kind of slip into, so we can be aware, so we can optimize this conversation.
Sure. I think it starts by speaking less and listening more, because it's really hard to elicit the patient's goals and their wishes and their hopes if you aren't asking open-ended questions. And I think that it is very easy, particularly because these are difficult decisions to make. And they're oftentimes quite emotionally charged decisions for the patients and their families. And so it's giving them some space to sort of talk that out. What is it that you're hoping for? And then stopping and listening for a while, rather than going into the spiel of the risk, benefits, and alternatives, and the 10% risk of this and the 25% chance of that. And I think that where surgeons get off course sometimes is that they want to obviously do their best for their patients, and I think they have an idea in their mind of what that looks like. But that may not be what the patient and their family have in mind. And I think that's how you can get off course, is by not giving enough time and space for the patient's voice, and for the family also to hear that, because I think that there is a lot of literature that says that patients understand that if they're going to the operating room, that it's for curative intent, no matter how clearly the surgeon may say it to the contrary. So, but having the family there to also listen to that, so that we're, again, on the same page going in. And then I think another thing that Tom does a really good job of saying is that these discussions are not a one and done. It's not 15 minutes between cases and you do the case and then, you do your standard post-operative check. These conversations are ongoing because the dynamics are changing. Certainly, if the patient was to have a complication, the disease was more advanced than you thought when you got in there, other things like that, that warrants a very different discussion. And patients and families need time to process this.
I think as you're demonstrating and as you're noting, these conversations and the discipline of palliative medicine requires a lot of experience and expertise. And that provides a perfect segue to our last article that we wanted to discuss tonight from Dr. Itzel and Dr. Johnston about the role of palliative medicine training in surgical oncology. I think our discussion tonight has highlighted for me that, these are challenging discussions. This is a challenging field. And I wanted to get your take on how can surgical oncologists who are faculty members, how can medical students, residents get the requisite training and exposure so they can be well-versed in palliative care and end-of-life care principles?
Yeah, it's a great question. And I think it's obviously a moving target. In many ways, I feel like our students are probably ahead of the game and probably could school their faculty quite a bit on kind of basic palliative care skills. I think that many medical school curricula now have a requirement as of June 1st of 2000 that they have some training in pain management and end-of-life care. The ACGME for general surgery also has some similar requirements. What we're lacking, though, are some guidelines as to how to do this and some specific processes of what is effective. And I think that the article by Johnston and his colleague point out is that comfort and confidence do not equate competence. And so what they pointed out in several research studies is, a resident or even a student, I suppose, or a fellow may feel like they have a lot of experience and they're confident doing something. But if you ask a patient and their family whether they actually were competent, did they get and elicit the patient's preferences? Did they adequately assess their pain or their end-of-life preferences? There can be a disconnect there. So I think it really highlights that we're now just kind of at the infancy of saying, yes, we think it's important, but the how are we going to do this is really a work in progress. For those surgical oncology fellows or those in gynecological oncology or hepatobiliary fellowships even, there's no paucity of palliative care expertise around them. What we have to do is prioritize it and make the education in these subjects equivalent and on par with making sure you know the indications for a transanal excision for rectal cancer or who needs a preoperative biliary stent for obstructive jaundice. But I think as of right now, it hasn't quite gotten the same amount of credit and importance that some of these other kind of harder topics, if you will, kind of more traditional topics in surgical oncology typically receive.
And another item that they touched on in their article was this notion of palliative care communication training. They cited the Comfort course as well as Compass Oncology with their seminar series. I was just curious about your kind of take, if you will, on these courses. I think it raises awareness. My concern is just the durability. Kind of, do you need, kind of like booster shots, if you will, to kind of reinvigorate the message? I'm a little skeptical that a 2 or 3 day course will impact or significantly change someone's communication skills maybe a year or 2 or 3 years after that 2 day course happened. I was curious about your kind of take on that.
I think you're exactly right. Any more than you would do a 2 day course in a robotic distal pancreatectomy and not do that case for a year and think that you're good to go. I think these are skills that have to be practiced. And many people in the palliative care world would tell you that a family meeting is our procedure and that there are appropriate steps to be done and preparation and ways to conduct that just the way you would in any other kind of procedure. So I think the first thing is it has to be prioritized in our training, and that when those conversations are happening, we engage the learner. I have been frustrated on more than one occasion to have my learners leave the room when I'm about to sit down and have the tough conversation, and feel like that it is a skill that has to be practiced. But I think that when folks don't feel comfortable, or they feel like they haven't had the training, or they checked the box and did the 2 day course, a year ago, that doesn't actually make them competent, as you're pointing out.
Yeah, and I do think those courses are important and help raise awareness and are part of the overall approach to raising competency in this area. Yet I wanted, my final kind of question and comment to you was the role of clinical fellowships, specifically in palliative medicine. As someone who yourself is board certified in palliative care, who should pursue these types of fellowships? And one question I frequently get from trainees is, when should they pursue them? Should trainees perhaps pursue these fellowships during their professional time, during residency? Should they pursue them after residency? And it can be challenging that after you've taken a job somewhere to then try to do this extra fellowship. So maybe you could provide some insight and recommendations around this topic.
While I think we definitely need more palliative care providers, we know that there is a workforce shortage, and I wish that there were more surgeons. We are seeing more. I'm certificate 39 or whatever. I'm happy to say that we're at least in triple digits at this point. But how do you integrate it? And this is where primary palliative care training comes in, and that's where training and residency and fellowship comes in. For those that are interested in doing subspecialty palliative care training, I am elated that the American Board of Surgery had the wisdom to allow surgical trainees to be able to do the fellowship during their traditional research time. I think it makes a lot of sense to plug it in there the way that others are doing Masters of Public Health or other, bench type research. Because I think I understand no trainee wants to go through 5, 6, 7 years of surgical training, take a year out to do a non-procedural year, and then hop into either their job or into their next surgical fellowship. So I think this is a really good time. I think it also sort of implants some experts and some ambassadors for palliative care into those residency training programs, which makes me really happy because I think it just elevates everybody's game when you have a content expert amongst the trainees themselves.
Those are great points. Well, Dr. Fahey, I want to sincerely thank you for your time and sharing yourself with us on this podcast. And I really want to thank you for all of your efforts in assembling such a notable group of co-authors who are leaders in the field of palliative care to contribute to this issue of surgical oncology clinics. I really think that the group that you assembled did a superb job in emphasizing the various aspects of caring for patients with cancer and the importance of integrating palliative care into all of our clinical practice. And I have no doubt that the readers of surgical oncology clinics will find this issue to be very informative and directly applicable to their clinical practice. So for that, I am sincerely grateful. So Dr. Fahey, thank you. And we appreciate all of your efforts.
Thank you, Dr. Pollack, for your support and for giving us a platform to educate the readers about what I think is a really important part of being just a cancer doctor.
Thank you.
Thank you for joining us for this Surgical Oncology Clinics podcast devoted to palliative care and surgical oncology. The series is available for individual print subscription with online access or individual online-only access. Visit www.surgonc.theclinics.com to subscribe. The series is also on the Elsevier digital platforms Clinical Key and Science Direct. Be sure to follow us on Twitter at Surgical Clinics, and you can subscribe to the podcast through Apple, Google Play, Spotify, or Stitcher. Thanks for listening.